Attendees. Welcome to everybody who has just joined here today. We're going to give it a minute or so before we really get started and let everybody else trickle in. All right, well, let's go ahead and get started. We are going to dive in here. I'm sure others will trickle in. We had a number of other folks signed up. Welcome to today's presentation, Practical Applications of Percussion and Vibration with our friends and partners at Integrative Dry Needling. My name is Eric Fernandez with Hyperice. I'm lucky enough to lead Hyperice's rehab division, really focused on supporting our clinical partners out there in the field. I'm going to, in just a moment, introduce our presenters, Frank and Nick from Integrative Dry Needling, and let them take over and do the majority of the talking today. But before we do, I just want to cover a couple housekeeping things. No worries about putting yourselves on mute. You are all in the audience. However, we would like to encourage your interaction. So if you have questions, topics you'd like to cover, follow-up points for our presenters, please use the chat function or the Q&A function throughout the presentation. We're primarily going to try to hold questions till the end, as we do have a lot of material to cover here today, but we'll monitor those questions throughout the conversation. And we'll try to get to them as best we can. On that note, I also really want to encourage you folks to reach out to us. If you have any questions, whether you are an existing Hyperice user, whether you're an existing student of Integrative Dry Needling, or interested in either one, we'd love to chat with you. And our contact information is below. I'll also post it in the chat once we get rolling here today. But to reach out to Hyperice and a member of our rehab team, it's just rehab@hyperice.com. And similarly, to get in touch with IDN, just info@integrativedryneedling.com. And on that note, I would really encourage you guys to reach out. If you're not directly connected with us, but have questions, whether you're an existing user, like I said, or somebody who's looking to find out, I'd love for you to connect with a member of our rehab specialist team. We can share the research behind our technology, our discounted clinical pricing, some of the clinical education videos and resources we have, some of which were put together by our friends at IDN and offer some phenomenal free education to help inform the use of percussion, vibration, and our other tools in patient care. Now, this presentation today will be recorded, and we will email it out to everybody after the fact. So if you have to step out early or want to share it after the fact with other members of your team or your peers, you'll absolutely be able to do that. Last note I want to mention, if you are interested in finding out more about the NRT course that Integrative Dry Needling offers, or any of their coursework, again, you can reach out. They're also going to be providing a 10% discount to everyone who attends here today, and we'll post that in the chat. So if you are interested, they wanted to offer a nice little discount to you to sign up for either their in-person or at-home on-demand study options. And similarly with Hyperice, in addition to our standard discounted clinical pricing, we have a special going on right now that we've worked on with IDN, where if you purchase Hyperice technology, specifically for every $2,500 worth of tech you purchase, you'll actually receive a free registration to their online at-home NRT study, which is a 12-hour CEU course that typically is a $500 registration. So again, I don't want to sell you guys anything else. If you're interested in any of those topics, research, finding out more about our clinical pricing supports, please reach out. So with that, I'm going to do what I promised to do, which is stop talking and introduce our two phenomenal presenters here today, Dr. Frank Gargano and Dr. Nick Sanders from Integrative Dry Needling. I will not try to butcher their backgrounds or bios. I'm simply going to stop talking and let them say hello and take over. So Frank, I'm going to turn it over to you, my friend.
All right. Let me share here. Awesome. Thank you, Eric. Thank you all of you for sharing a little bit of your lunchtime with us over this next, roughly, I think we're in for 45 minutes. We're going to talk about the practical application. Again, I'm going to have to do some talking initially here, but Nick's going to do some fun stuff with some videos and showing you some practical application things. But this is really going to be talking about pain, right? So we know pain has a neuronal excitability component to it, and also inflammation. So that's one thing I'm going to go over is looking at neurogenic inflammation and really how that applies to the use of these types of tools. As we go through. And then percussion and what its relationship is to peripheral to even central types of processing. So Nick will go through and look at that. And then one of the things that's important here too is vibration's influence on fluid dynamics, and that's circulation as well. So in our courses, we say a majority of musculoskeletal pain is a result of a lack of circulation, right? So if you can improve circulation, you can improve a lot of musculoskeletal pain. So we'll talk a little bit about how you go down those pathways and look at that. And as I said, then Nick will do some cool stuff for us on the actual application of it with some videos. Now, my background really, I started integrative dry needling, and we teach courses all over, but our system is based on a neurological model. What that means is we look at things like we're going to talk about neurogenic inflammation, its relationship to peripheral nervous system and central processing, and how that comes out and it shows as trigger points, if you will, as it's shown. And in that particular course, our model was for people who could dry needle. So Nick and I got together and said, look, there's a number of people, either therapists or chiropractors, for whatever state reasons, they can't needle. So we came up with a course called Neuro Release Treatment that takes our neurological model and applies it to soft tissue tools. And that's what you're going to see a flavor of today, is being able to apply that, much like we do in the neurological dry needling model, utilizing soft tissue tools. So now, pain, as we start, right, that means a lot of things to different people, right? Is a sensory and emotional experience. And really what I'm more interested in this definition is looking at it, is it actual or potential tissue damage, right? So there's a differentiation there and how you treat those things a little differently. So I want to kind of get into that as we go through. And one of the things that we talk about a lot, and really, I think anybody on this call's profession, we talk about muscle pain, right? So, and I put it kind of in the quotations because I want to challenge that thought process for just a second. So when we look at actual muscle pain, I think we can all agree that mechanical, chemical, or physical injury can cause muscle pain, right? I think we can also agree that repetitive strain, overstretching, the contractions, that can cause muscle pain. We also know that the diseased viscera has a shared circulation, has a shared neurology. So things like small intestines and IBS and all those types of things can refer into the external body, our musculoskeletal model, right? And create muscle pain. Grandma's knee, right? And she's got degeneration of her knee joint. And when the pressure's low, inflammation, irritation gets high, muscles get inhibited, she gets some trigger points in those quads, she can't get up to step, right? As the weather gets better, high pressure comes in, that starts to resolve, all of a sudden those trigger points sort of go away and she can step up onto the step, right? So those are the four kinds of things we think about along the lines of muscle pain. And I want you to take that concept and kind of put it off to the side. Let's talk about something different as a potential generator of that, and that's neurogenic inflammation. And what we know about that is that all sensory fibers and nerve endings of sensory fibers have the ability to release sensitizing chemicals, substance P, CGRP, and others, right? So in a pathological situation, that nerve can actually create that. And when these chemicals are released out into its little microenvironment, it immediately changes neuronal excitability, microcirculation, metabolism. It doesn't do nice things to that particular area. And we know that when the nerve starts to have irritation, then it starts to send a signal to central processing, says something's going wrong. Central processing sends back to the muscles and says, guard. Right? Because one of the major reasons we have muscles is to protect nerves. They move us, they do all kinds of compression, but they protect nerves. So I think that pathway that we just talked about gives us some genesis of why we get some of those trigger points that we see. Now, depending on how much sensitizing chemicals, and Shaw and a number of others did some really interesting work around that, but the higher the level of those sensitizing chemicals, the more the patient will walk in and say, I have pain right here. It hurts here. Right? So that's kind of an active trigger point. And then as those sensitizing chemicals kind of wax and wane and change, as they start to drop down, now the chemicals aren't generating a conscious awareness. So then you have to poke on it and they say that hurts, right? So there's our latent or our passive trigger points. So these people kind of come and go with these levels of sensitizing chemicals in their presentations in the clinic. So we understand that piece of it. So now the question becomes, if you can buy into the idea that the nerve itself is the perpetuator potentially of this pain, of these trigger points even, right? That they're the reasons for the modulation problems that we're having in and around the nerve and around the muscles themselves, then conceivably an intervention that decreases the mechanical, the physical, or the chemical irritation by normalizing what? Blood flow, right? We said how important that is. And then also releasing that endogenous muscle contraction, call it a trigger point, right? Could that improve your overall treatment, the improvement of the patient? Could it improve the efficacy of that treatment, right? The efficiency of that treatment? And the answer is empirically, absolutely, right? That's what our whole system is based on, is that neurological model. And that's why a lot of the research that we're doing is going in and around this concept of how we treat patients. So you'll see that more and more research come out from our institution looking at those types of things, right? Now, good knowledge, understanding of the peripheral nervous system is certainly important, but we also have to do is understand, does neurogenic inflammation even exist? Like, how do we know that it actually even exists to be able to go and treat it? Now, a few years ago, we did not have the ability to really look at these things at a high level. And now, because of T2 weighted MRIs and the way that they're using them, we have a really good diagnostic to do this. So I thought I'd explain this more in a research study, right? So this was a research study that came out, and for, I would imagine, the majority of us on this call, whiplash is something that we treat. And this was a study that looked at people who had various stages of post-whiplash. The average was about 18 months. Right? So 18 months status post-whiplash, they continue to have cervical pain. Well, obviously the healing should have happened by now. So what is still perpetuating the pain? So they did a T2 weighted MRI, and essentially what they found, and they did it into the cervical spine, and they looked at the roots. And it was a positive finding. So a positive finding on T2 means that there is nerve edema, which is a direct result of inflammation. Now remember, edema and inflammation always kind of go together. And it also shows vascular changes around the nerve itself. So they hypothesized reasonably that these people had persistent cervical pain because of the findings in and around the nerves themselves. So they took it one step further, though. They said, okay, now let's take a look down at the median nerve, right? So they did an MRI of the median nerve. Guess what they found? Positive T2 signal, which again means inflammation and irritation around that area. And this, by definition, is the double crush that we see in clinical situations. And this is a nice explanation for it. So when we start to think about how that looks, and again, it's the presence of neurogenic inflammation within those nerves themselves. And remember, anytime you have an injury, an impediment, a compression, an entrapment in one part of a nerve, it has the opportunity to affect the entire nerve going all the way back, right? There's a flow to a nerve, there's an axoplasmic flow, there's an antidromic and an orthodromic flow. So if it's impeded anywhere along that lines, the nerve as a whole has an issue and an opportunity to have additional problems. So if you're only treating locally and you're not looking at it on a bigger scale, you're going to miss a lot of the treatment options that you have and the ways of the efficacy and the efficiency upon which you get people better. So that's a big focus in a lot of our courses and what we do. So it's the nerve in our minds that it is the perpetuator of that dysfunction, and it not necessarily just in a muscular type of source of that generation. It goes much bigger than that, right? So now we want to be able to look at this and be able to look at ways of applying assessments and clinical applications on a bigger scale. And that's what we're really going to talk about today as it relates to using percussion vibration, some cupping, even maybe some A-stim types of concepts, and how to look at it on a bigger scale using the peripheral nervous system as a model for us. And so I'm going to turn it over to Nick now for him to show us some of the clinical things that he's doing right now with it. So I'll stop sharing.
Give me one.
There we go.
All right, Frank, thank you for the introduction, and Eric as well. Always doing the best description of our course that I've seen from Eric every time we do one of these. So thank you guys again for joining us. I want to dive a little more into how we're actually using this in the clinic. So I've been with Frank in integrative dry needling since I was a student in school. Been doing dry needling since 2012. And so I was introduced to this neurologic approach very early in my career. And I think it helped clarify things for me because, you get a lot of different concepts thrown at you and where does it all fit in? And when we talk about pain science and the neurologic aspects, I really think it makes sense of things and simplifies it in a big way. So we have a cash-based self-pay kind of physical therapy model in Northeast Ohio. So we're kind of doing the cash hustle in the gyms. And I really think being very good at manual therapy has allowed us to do that. And certainly having the Hyperice products as part of what we do is a big piece of what we do. It's to a point now where pretty much every client gets some form of vibration with their treatments, whether it's at the beginning or the end for a calming effect. We're using it a lot. And I think we're starting to see some research to support that. And, we've been doing this NRT course for a couple of years now. And I'm continually surprised by how few people are utilizing vibration as a part of their clinical treatments. And I think a part of that is just maybe it's the research or maybe it's we don't know what it does, but we're starting to see this stuff evolve and that we can get big time changes with really simple techniques. So really cool stuff. Here's a 2020-21 study looking at vibration for muscle soreness, muscle damage after exercise. And it's a small study, right? But we have to start somewhere. But as simple as laying on a vibration mattress compared to placebo, and our vibration group showed changes in pain scales related to DOMS. What's interesting is we're also starting to measure some of these blood chemical changes. And like Frank talked about, as we're talking about neurogenic excitation, really we're talking about inflammation around the nerve and what's creating that pain signaling. And so when we start looking at this at that deeper level of what's happening at a chemical level and how vibration can impact that, we got good things happening. We're also seeing research that looks at more than just pain, right? So here's a study from Yang in 2021. Again, smaller study. We have 15 women here. Your average age is 72, so it's an older population. In this study, they actually used passive foam rolling. So they took the Viper foam roller and they had the women in the study, they had them laying down and they passively applied the roller. So we're just rolling the roller on top of the person, if you will, kind of went throughout the body there, and we're able to measure functional fitness testing. So we saw improvements in strength, cardiorespiratory endurance, dynamic balance. So a lot more is happening here than just muscle tissue type effects, right? If we're able to change dynamic balance, we did something to the sensory nervous system, right? And so we want to start looking at that next level of what is happening from a sensory, a mechanical input, and a chemical change. And so when we talk about sensory input, we know that we have different sensory fibers and they're going to perceive different inputs, right? And whether we're talking stretch or vibration or deep pressure, they all have different inputs. And as a clinician, I don't know that we necessarily need to know the exact science behind what each of these different sensory receptors does, but understanding that it's going to impact the system differently. And some people are going to respond to different stimuli different than others, right? There's patients that you can push on as hard as you want, and they're going to do just fine. And then there's people you barely touch their skin and they're jumping off the table. What are those differences? And how does your treatment change when you get those two different patients on the table, right? Some people love deep pressure, some people can't stand it. So we want to have options so that we can apply a different stimulus to kind of meet our client, right? And let them have a positive experience, but still be able to tap into the sensory system, still be able to get those chemical changes we're looking for. This is an interesting study from Men's. They were looking at thoracolumbar fascia, and kind of what Frank was talking about with our T2 weighted MRIs. The nerves they have varicosity, there's little bundles where they're storing these chemicals. And with different stimulation, they're going to release these different neuropeptides to change the blood flow, right? Whether we need vasodilation to get more blood to the area or vasoconstriction, like if you have a new injury, you've got to constrict the area so blood can't pour out of a new cut. But the nerve is what's going to create some of those vascular changes. What we're going to look at from a stimulation standpoint of what's going to target that nerve is this mechanical stimuli, right? We can apply with manual therapy, we can apply some type of mechanical stimulation to hopefully have an effect on that nerve. Now, with manual therapy, I can't tell a nerve, I can't tell a muscle to turn on or turn off, right? I don't have that power. My goal is just to make the system feel safe, to kind of restore a comfort level so that hopefully we get a balance. We don't get an overreaction, we don't get an underreaction. We're just trying to make the system feel safe and comfortable. And I think for the most part, that's going to be our goal with manual therapy. And that's why we want you to have a plethora of tools to use to be able to impact that. On the flip side of this, what is happening is not just happening at a local tissue level. Your brain is perceiving touch. This study it was pretty interesting. They were looking at brain activity in the insula, which is a deeper processing cortex of the brain, super fascinating area. It's related to a lot of growth stimulus, and there's some interesting research in chronic pain and what insulin does from growth triggering, cancer research happening in the insula area of the brain. So pretty fascinating area of the brain. But what they looked at is comparing a soft touch, a manual touch from a hand, soft stroking touch, to vibration. And what they found is that the anticipation of touch was different, whether it was vibration or personal touch, as well as how the deep motor cortexes reacted to the stimulus. From a clinical standpoint, that means a lot to me, right? If I wanted less personal touch, I have vibration as an option, right? If you're working on an area or a newer client that you haven't kind of built a rapport yet, now we can start with vibration. It keeps a little distance between you and them. It's a little less of a personal touch. On the flip side, we can add touch when I want to create a little more of a calming effect. I want to create a little more relaxing effect. So now we can combine what we're doing with our hands as well as what we're doing with tools. So again, just continuing to think about this at a deeper and deeper level. This is one of my favorite studies that we've present in the course. They put people in VR goggles and they had them wearing EEGs so they could, monitor brain activity. They put an apparatus on the back of their hand near their thumb that gave them vibration and a little bit of a stretchy sensation. And they recorded what the brain did when they applied the stimulus. So everybody got the same stimulus to the back of their hand, but what they changed in VR is the look of this creepy guy's face. And what happened when they changed the facial expressions of the little VR guy, it changed how the brain responded to the same stimulus. That's a super powerful thing to me, right? Because we always want to talk about, what's happening at the tissue level. But as a clinician, how I approach that patient, my demeanor, my facial affect, the environment around me, all of these different cues are going to change the way that person responds, right? And I'm sure you've seen it as clinicians. If you're having a good day, people have good responses to your care. And if you're kind of in a crummy mood, it seems like nobody's getting better, right? There's some realness to that, and how confident you are and how much you trust your manual therapy skills, I think it's going to play. And so when we talk about how do we add these tools, we want to be able to include multiple different tools, meet that person where they're at, not just at a mechanical local level, but thinking about the chemical changes, thinking about how the brain's going to respond. All of those things are going to play, right? Now, the fun of this is that these tools are simple, right? This is my 2-year-old daughter. She can work a hypervolt. She can put cups on. It's not real complicated. The magic in being good at doing vibration, at doing cupping, is being able to decide when to use which tool, how to apply it in that patient's injury history, right? Is it a new injury or chronic injury? Are we dealing with something that might have a central or systemic response to it? All of those things come into play. But using the tools, piece of cake. So what we want to do this weekend, we have several, I believe it's 8 or even 10 different case scenarios on the Hyperice clinical education platform that you can look at for specific examples on maybe where to treat for some different things, some basic kind of treatment approaches. So what I wanted to talk about on this webinar is more of a kind of dive a little deeper into a knee pain case scenario. And what we like to look at from a neurogenic approach is, can we look at what nerve is affected, and then how do we progress a plan of care, and how do we incorporate some of those different tools? So one of our athletes that we work with in Northeast High, his name's Cam. He's a pretty high level CrossFitter. He's getting ready for the quarterfinals here, and is dealing with some knee pain. So we took some pictures and did some treatment applications. But when we talk about manual therapy, I like this idea of passive versus active treatments. When we're starting, new injury, new pain, a new client to you, passive treatments are a little calming, a little more relaxive. So we start there. And I think, this kind of idea of just laying on the table, using the hypervolt along a nerve distribution, superficial, kind of a gentle treatment, and kind of what we think about most of the time, I think, when we see somebody using a hypervolt. As I want to progress to getting a little deeper treatment, maybe have a little more of a blood flow effect, now I can add cups to the situation, right? So we go cupping, we're going to get a circulatory, a decompression type of an effect with the cup. You can see the heat coming off of those cups, are steaming up a little bit. We got some redness in there, so we're getting some blood flow changes, and now we add vibration on top, right? So we're starting to combine effects, and we can start to go, from a superficial to a deeper treatment type of an idea. Now, Cam was having some pain right on the kind of top medial side of his kneecap. strummed down a little bit into the inside of his leg, but mostly right on top. So, the first thing when you think about pathologies, right, it gets complicated. Is he having a patellar tracking issue? Is it an IT band thing? Is it something with his VMO? Is it meniscus, right? You can start going through all these different pathologies, and it can get complicated real fast because now you're trying to do all the clinical tests, and how do you know which one's which? And it's only a day old, right? This is a brand new pain. But from a neurologic lens, I can quickly go, it's his anterior femoral cutaneous nerve. As it's coming down to the inside, maybe we're getting a little bit of saphenous nerve distribution, the sensory nerve distributions, all coming off of the femoral nerve as its primary roots. Gives me a quick, easy treatment, right? I know exactly which sensory nerve is giving him that neurogenic excitation, what's giving that nociceptor feedback to the brain. I treat along that distribution, right? And so we start with some passive things and we kind of build, right? If I want to really get onto that anterior femoral cutaneous, I can throw a silicone cup right on the kneecap. Now we add vibration right to the system. So now I'm getting decompression of the kneecap. If it is some kind of quadriceps tendonitis, tendinopathy, I got some input through the tendon itself. And now we add vibration. And you have to love slow-mo cups with hypervolts because you can just see the tissue movement, right? You can see the patellar mobility. You get a lot of that movement through there. So kind of a cool thing and a way to impact the system, again, with something that feels comfortable. Now, as we want to work deeper here, now we add dry needling, right? So cupping is going to get a certain depth. We're going to get some tissue movement to a certain depth. As we progress, we can get into a deeper type of a treatment, maximizing some of our blood flow changes, some of those chemical changes that we look at, and a larger input to the immunes and nervous systems with needling, because it's an invasive type of a thing, right? But now we can needle right into around that quadriceps tendon. We are into that anterior femoral cutaneous nerve distribution. We're following saphenous nerves down the inside of the knee. And then we can hit opposite side with some things in and around the common fibular nerve. So we can get into some of those major nerve distributions in and around his knee, deeper stimulation to the system, right? Something we've been doing recently, I'd say the last year and a half now, is adding vibration to the needles. So traditionally, you'll see people flick needles, you'll see people twist needles to try to increase that sensory feedback to the needle, right? You're trying to increase more input to the brain, get some of that brain feedback. Well, now we can do it with vibration. So this is another client of ours with some knee arthritis. So we got needles in some of the same distributions. We got the Femoral roller underneath, and now we're getting vibration from the roller. The beauty of having the roller underneath the knee is the major blood vessels, all the lymphatics running through the back of the knee, popliteal artery, tibial nerve, kind of hitting some of those nerve and lymphatic distributions there, gives some nice input. Now, if you want a little more direct approach to the vibration, right, we can use the hypervolt right in and around the needling. You got to be a little careful with this. Sometimes you'll vibrate the needles almost out. So you got to be a little careful with your proximity there. But now we're getting a lot of input. I'm still getting that nice sensory and fluid exchange, but we're getting more input in through the needling itself. So a lot of cool applications combining some needling with vibration, which we do a lot of. And, I was talking with Eric and Frank, there's not too many scenarios anymore where we do dry needling without some version of vibration, whether it's beforehand to kind of prep the tissue to kind of calm down the sensory nervous system ahead of time, during, or after, right? You do some type of manual therapy, whether it's dry needling or massage or whatever it ends up being, and your patient has a little bit of soreness, your client has some soreness, vibration after can be super calming. So just kind of throwing multiple inputs to the system. Now, Cam is a consistent client of ours. I've known him a long time, so he's used to these things, but we kind of threw a bunch of stuff at him at one day. But this might be a progression of things, right? So day one, it might be passive superficial treatments. And then as you're progressing through a plan of care, now you're adding, if you're getting a positive response, you can add depth, you can add input to the system kind of as somebody progresses through. Adding motion. When you're able to, it's not always a thing you can add, but when you're able to, I love adding motion, right? Because now you're activating motor patterns in the brain as well, but you're changing that input. So something as simple as, putting the roller underneath with some vibration, letting them do like a short arc quad, right? Very simple. Not a lot of complications there. To now adding a weight bearing component to it and having him do his provocative movement. So him and I are working together here If I get the cups on the right spot, he has no pain in his knee, right? So we move him around, we change that input a little bit. We're obviously getting good blood flow to the area, and now he can move in a pain-free range of motion here, okay? We could add vibration to the same setup as multiple inputs. Another one of my favorite ways with knee pain specifically, to add vibration and cupping is more of like a long arc quad or kind of a seated knee extension kind of movement. So we throw some cups on. Here we're doing vibration of that saphenous nerve distribution, and then letting Cam add some active range of motion to it, right? So now again, we're getting movement, a little less intense than maybe our squatting that we saw earlier, but we're still getting some movement with some cupping, right? So a lot of ways to progress that through. Now, when we look at the pain in the knee, right, we know that you don't end up with knee pain without something going on at the hip, ankle, or maybe the spine, right? The knee can't move in isolation like that. So there's going to be some functional limitation, whether that's ankle or hip or back. So we're going to trace it, right? And so we know it's anterior femoral cutaneous nerve or saphenous nerve. We know that comes off of the femoral nerve. And then segmentally, the femoral nerve is going to come off of L2 to L4. So when we come up and we start pushing on Cam's back and start checking for tension, tone, mobility, those types of things, interestingly enough, you push right L2, L3, and all of a sudden he's like, "Ooh, that one's tender," right? And it's a lot of what Frank was talking about with that neurogenic inflammation. I'm not saying it's a radiculopathy coming from his spine, but you're going to see tone, you're going to see guarding, you're going to see sensory input changes. And now by impacting that area, it's going to change the treatment effect. So again, starting passively superficial, we got the fork attachment on the hypervolt, and we can work right through those. We can work right through those segments. And again, just changing the input. Progressing deeper, same idea. We can add cups, right? So now we're getting a little more tissue distraction, obviously a little more fluid exchange. We add vibration. Mark Hernandez, one of our instructors, often does a demo with a tube of ketchup, right? And you got the tube of ketchup, the ketchup's not moving anywhere. And, you hit the bottle, right, with your hand to get it to move. Well, Mark puts a hypervolt on it and it vibrates and then it moves, right? So there's a dynamic property to vibration that might help some of that viscosity and some of that stagnant fluid in the area. So now we got the cupping, which is going to move some of that fluid in the area, add vibration to it. It's a really nice combination, really nice combo. Regionally, you want to work on some of his hip mobility, right? So his right hip was definitely stuck in a little internal rotation. So now we can do some pin and stretch, right? We're gonna pin, have him go through mobility. Save your thumbs, right? Thumbs all beat up at the end of the day. Instead, we switch to the hypervolt. I switch to the bullet attachment, that trigger point attachment, so I can get a little deeper. And now I can pin hip and go internal rotation. If it has a tibial internal external rotation, some of you people that maybe have done Mulligan in the past and you're working with some tibial rotation, that clears the knee pain. Well, now I can do some pin and stretch with my hypervolt to work on some of that guarding in the popliteus that might be related to unlocking and locking. So again, a lot of options here to save your hands by using tools, but also not only do I get deep pressure, I get vibration, right? So I get multiple inputs to the sensory nervous system. And now the beauty of this is these things become your home exercise program. So, we need ways to get him out of pain quickly. He's got a competition coming up at the end of the month. We need things for him to do that can kind of clear this quickly. So we send him home, we give him the roller or the Hypersphere Mini. And now he's hitting some of those same distributions. So focusing on anterior femoral cutaneous nerve distribution, going down the middle of the quad more or less in that distal third, or saphenous nerve coming through the inside edge. He can roll some of those same distributions. We're still getting deep pressure. We're still getting vibration. We can add some shear if we wanted to this. But all of a sudden now it starts to open up ways for him to treat this at home. Quick, convenient, easy things for him to do. And then, of course, you got to finish with the Normatex, right? So you want that lymphatic change. You want to move fluid. Finish your session, get them in the anti-gravity chairs, throw the Normatec boots on, add some compression, some feedback there. Really, really nice combo. For those of you that have the Venoms, the wearables, putting the Venom on their back in that L2, L4 distribution for Cam, put the Venom with vibration, add some heat so you get some thermal input. It's just a nice combo, right? Next level is going to be the core devices with some of you can have them meditate and get some mindfulness training in at the same time. So, it really gives you that kind of complete, you get the compression vibration for the fluids, you get thermal changes, you get mechanical changes, and then we can work on some of the cognitive type things as well. So a lot of different options here to treat along those lines. So of course we kind of dove into a knee, but in the NRT course, we're going to cover the whole body. These are just some fun kind of videos from the course. Love looking at feet. We're talking about great toe extension for glute activation, balance control in your older populations. Talk about sensory input, right? Like, how are you going to mobilize a toe that many times, or how many people haven't splayed their toes or gotten any big toe movement in many, many years? Simple, feels nice, a lot of sensory input, and now we're getting movement through that joint that maybe we haven't had in some time. Here's another video through the course. This is one of our students. You can see some of our kind of nerve treatment locations here. Here's one of our students doing some vibration right along the sciatic nerve distribution. We got some cups in the middle. You could add movement to this as well, and just kind of making our way through there. Here's two of my clinicians in our clinic at FIT, Austin and Kara. They got the fork attachment, doing some upper cervical work. Kara's doing some cervical retractions while we're getting some input through vibration through the suboccipitals there. So another, again, just starting to combine movements. Just had a client the other day, back pain's disky kind of back pain. It's pretty much all gone except when she deadlifts. Put cups on, have her go through a deadlift active range of motion, pain's gone, right? So a lot of ways to alter input. This was a fun one. This is literally the last, well, now 4 weeks. This is one of our clients. He had some type of lifting injury at work, bicep related. He does have some balling of the muscle tissue when he flexes. I do not think it's a complete rupture, but no imaging has been done. This was week 1. His range of motion, shoulder elevation was probably in the 145 range, 150 maybe, without pain. We threw some cups on it, and literally that cup on there, you could see it turn red while it was sitting there, like immediately bright red. We did some vibration to make sure we got some movement. We did some very superficial needling along that bicep, just felt like veins running through there, some lymph nodes living in that area. So anyway, superficial needling, kind of combined that. Came back week 2, pain was much improved. And look at the difference in the cups, right? So I didn't stopwatch these, but they're on about the same amount of time, and you can see the difference in the color change, right? So definitely some differences in the fluid in that area, how much micro rupture is going on in the capillaries. Pretty cool. Week 3, even less. Now, instead of this like yellowish, brownish color of the bruising, we got this nice kind of healthy pink looking response to the cups. Still getting a little bit in around his pec of bruising, but really nice, right? I saw him on Monday. Full range of motion. If he overpresses flexion, he still gets a little bit of pain, which we did some cupping and vibration on his AC joint, and that went away. And he's going back to work, I think, today. So pretty quick response from some type of what I would guess was a partial tear. We were in that 4-week window, and he's doing really well back to work. Had him picking up 45-pound plates in the office with no pain. So pretty cool responses. Now, it's an N of 1. We have no comparisons here, but I really love, the visual of seeing the change in what that blood flow looks like from week to week. Let me go back one. So in the actual NRT course, our goals here are really to look at pain and assessment and treatment with that neurologic lens. I found, especially early in my career, pathology first thinking is complex. You need all these clinical tests. It's hard to figure out what's going on. Neurology is right in your face, right? When you know where the pain is, you know which nerve's involved. Now you still use all your assessment skills, all the movement testing that you've done, your clinical testing, to figure out where along that nerve pathway maybe the pain provocation is coming from. So it's not going to change your thinking. It just gives you a neurologic lens to treat the pain distribution. And when you start thinking about it from a nerve and chemical standpoint, it really simplifies complex things. Things that aren't responding the way you think, or maybe don't meet the algorithm or the textbook definition of how it's supposed to work. It really just gives you another layer to understanding how to apply your manual therapy techniques. And I think just simplifies it, right? Clarifies the picture for you. In the full course, again, we have some videos on the Hyperice education platform, but we really go through most of the major nerves and sensory distributions and look at common treatment areas, whether those are nerve fascial entrapment points, where the nerve's going through a fascial or bony foramen, where nerves split. We look at multiple areas to treat the whole body and give you kind of that shortcut of where you're going to find tender spots. Clients ask, how'd you know it was going to hurt there? Well, if you know the neurology, where that nerve's getting compressed, that's where the fluid's going to sit. You got fluid, it's a non-compressible fluid. That's what's going to create the compression, right? So if we can treat those areas, it's going to take, hopefully reduce some of the pain input that they're getting. We also use all three tools. I know we didn't show much instrument assisted work here, but we do show that in the course as well. Vibration in that situation is usually done before or after, not with the tool, but we do a lot with cupping and of course the percussion, all the different Hyperice devices. The course itself is 12 hours for most rehab professionals when done online. It is a chapter-based online learning module. We film the course with the intention of making it online, so it's broken into chapters and done like an online course should be. And then we also have the live course. So our goal is to help you, again, add that neurologic lens, but also speak a consistent language, right? When you speak neurology, you speak pain science. Again, I think it makes it simple for you, but it also makes it simple for your client to understand, makes sense of some of those weird pain situations. So yeah, hope at some point we can see either the online course or the live one. As Eric mentioned at the top of this, we do have a code right now for you, NRT10 at checkout. That'll give you 10% off either one of the live or the online NRT courses for you. Okay. Thank you guys for joining. I hope you guys were able to take something out of this, and I will turn it back over to Eric.
Awesome. Nick and Frank, thank you so much again. Every time I tune in, I'm challenged. I Google a lot as a non-clinician, but I always learn something, and I really appreciate that. And something I want to color in too, because I'm not sure exactly who's in our audience, but having seen the advanced signups, this is a great course, whether you are a physical therapist, whether you're a chiropractor, or other specialties as well, right? I believe, correct me if I'm wrong, Nick, but I mean, if you're an LMT, if you're an AT, even I think if you're a personal trainer, right, there's opportunities to take this course and learn, right, enhance the solutions you're able to provide to your patients, your customers.
Absolutely. We've had multiple massage therapists take the course, love it. It adds that extra dynamic of the neurology to what they're doing, gives them opportunities to save their hands. And then we've also made sure to invite some of my CrossFit coach friends and personal trainer friends because their clients are using these tools. They're using them on themselves. They're asking their trainers to do things. And so learning the best ways to apply them, not just kind of beating the heck out of whatever hurts the most, is really our goal. And I think all of my coach trainer friends that have taken, whether it's online or in person, are really appreciating that fact.
So let's open it up now to questions. We have a couple that did come in through the presentation, but if you've been waiting patiently, again, we've got, we'll probably go a little over. If there's questions, I think both Nick and Frank said they're good to go to the top of the hour. So please post those questions. First one, Nick, Frank, whoever wants to take it, coming in from Scott. Are there protocols to use these tools during the acute and subacute phase post-operatively, either for the peripheral or spinal procedures?
Go ahead.
Yeah, so I wouldn't say that we have protocols in place, mainly because we don't want to give you blueprints. And in our opinion, everything is so unique, right? And even something as what should be standard as a surgery, some people come out with a ton of pain and some people feel great and are up and moving, sooner than you'd expect and all those kinds of things. So what we want to talk about more is that patient experience and how do you apply the tools for them. And I think especially in a post-surgical scenario, our goal is just to make sure fluid's moving in and out and that the system stays relaxed so the person can heal as quickly as possible, that there's nothing from a sympathetic tone standpoint or a guarding standpoint that might prevent healing. And so trying to keep that area relaxed. And then also, when you look at it from a neuro lens, say it's a knee surgery, I don't always have to just treat their knee, right? So I can do gentle things to promote blood flow in and around that area, but then I can go back and treat the spine, right? So I can have pain input, pain desensitizing techniques without messing with surgical sites. So I do think it will give you a lot of options in your post-surgical situations.
Yeah. And I also think too, that there's an opportunity pre-surgery, right? You want to get somebody going into surgery that has as clean a slate, if you will, as possible. So I think there's some opportunities on the front end. And certainly what Nick has said is looking at things in a little more global situation and not having to necessarily be in the surgical site. And we get a lot of those questions in our needling courses too, is when can you actually needle after a surgery? And taking the same principles and same concepts doesn't have to be in the knee. It can be above and below. And so we talk about a lot of, timing issues with it as well. Got one more.
Yeah, absolutely. And just a quick one, but somebody did ask, Nick, somebody was really interested in the cups you were using where you were applying the Hypervolt to them. Is there a particular cup you like or would recommend?
Eric, again, I'm waiting for you guys to have one that vibrates. But yeah, the two cups that I use the most, there's a brand that I buy on Amazon. It's called Kangzu, Kangzhu. We do have a link available to it in our course, but it's the $25 and they work really well. Those are the hard plastic pump handle cups. And then the silicone cups we use are, we use the Cupping Warehouse brand. And if you're going to apply directly to the cup, you want the silicone. Nice for joints, nice for glide cupping where you're doing movement cupping. If you want a little deeper, more pressure, the hard plastic cups are a little better.
Yeah, cuppingwarehouse.com. They're cheap and
Nice.
they do a nice job of delivering stuff. Yeah.
Awesome. So another question that came in, which is, I'm gonna kick it off. I'm gonna start it because it's a little bit towards directed Hyperice for questions. So the question is, how much to charge for each patient for these extra services? Insurance doesn't cover any of these, but I think this would be a great addition from a cash service. Nick, I'm going to kick that one to you in 1 second. I'm going to answer the second question first, which is also Hyperice doesn't give very much discounts to providers to buy and sell the units out of our office. And then it goes on to talk about matching, special sales online. So I'll quickly address that. And Lisa, I really appreciate you bringing the question. It sounds like maybe we need to better connect. So I would encourage you to reach out to rehab@hyperice.com. Hyperice does offer a clinical retail program and Nick actually participates. So I'll let him talk from his experience, but your pricing, it sounds like, again, there's a disconnect because certainly, we have, I think, fairly discounted clinical pricing, and typically the margins providers who engage in retail see somewhere between 25 to 35% margins on those retail sales if you choose to engage in that program. So again, any questions related to Hyperice in terms of how we support pricing, education, retail programs, cash-based services, please reach out to rehab@hyperice.com and we'll make sure you get connected with a member of our team. You're squared away. But Nick, to you, I know that you use all of these products consistently in your clinic, as you said. How do you charge for them? Do you bill anything through insurance? And maybe, how's retail worked out for you guys?
Yeah, so yeah, we've done the retail for probably 2 years now, year and a half. It's gone fairly well for us. We have, again, we're kind of a smaller set. We do offices inside of gyms. But what we have found is if you're using the tools, what a great way to send them home with something to do. And so people want to buy them because they're like, okay, I want to do this at home. And most of the things that they can do some version of it themselves. And so I think the barrier to entry for the consumer is they don't know where or how to use them, right? So when you see them in the office, you show them what to do, where to do it. We draw X's on people, we film where it's at, whatever it is, right? And then they want the tool, right? So they end up buying it off of you most of the time, which has been really great for us. We sell a lot of the a good percentage of Hypervolts, but then a lot of the Hypersphere minis and the foam rollers, right? Because that's really easy for somebody to do themselves, especially if it's a back or a neck or whatever. So no, that's been great for us. And then as far as in-clinic pricing, that's so varied. I've been in the cash PT world now for over 5 years. I've seen people charging as low as $60 to as high as $200 and some for a session. We do provide a super bill because it's a physical therapy service in our world. So we bill it under manual therapy, and we'll give them a super bill. So they pay self-pay on the front end, and then they can submit it their insurance on the back end. In the insurance model, from a cash standpoint, as an add-on, the maintenance membership thing is fantastic. So whether you're in the massage therapy or PT, chiro, athletic training, having the ability to bring people back for maintenance visits is a game changer. So we have a huge bulk of our clients that come in once a month. Some of it's just feel good stuff. And then some of it is like troubleshoot naggy little things before they become functional limitations. So can't do that with insurance. But if you're just trying to keep your clients healthy and moving well and doing what they want, it's been fantastic. So a lot more treating small stuff instead of big, disaster problems, which is nice.
Yeah, I love that, Nick. I think so many great things there. And, I've heard several people out there, Michelle Colley comes to mind, but many others talk about this concept, right, of physical therapists being ultimately being the primary care of MSK, right? Or should be primary care providers. And I think that applies, across other groups as well. I mean, again, I think a lot of these specialties that we're talking about, I think there's such an opportunity for folks like yourselves to be an essential part of that sort of overall approach to health and wellness, right? Whether it's just coming in, like you said, once a month for some general aches and pains, or, nipping something before it becomes a major issue. So something I'll just share from my perspective, working with, thousands of clinics at this point over the past 5 or however many years, that is a real thing, right? Being able to use things like recovery tools or some of these adjunct services as a way to sort of change that perception with your patient population, right? That, hey, this isn't just a place I go when I hurt, when I have an acute pain or injury, right? But that I can be going to consistently. So I think that's a value. I don't think Hyperice tech is going to do that on its own. It's not a cure-all, but I think it can be a great way to tell that story. And I will mention it does vary state by state, carrier by carrier, and even contract to contract. But generally speaking, Normatec is a covered insurance billable service under the appropriate scenario. So I know the question had come up, and again, Nick, you're more of a cash base, but for folks who are accepting insurance and billing insurance, the vasopneumatic code CPT 97016 is fairly tried and true for Normatec. It's an untimed, unattended code. Again, reimbursement varies heavily, but I typically see anywhere from like $12 to $18, $19. Again, depending on the carrier, state, contract, et cetera. So definitely billable for the Normatec session. And then to your point, Nick, on the Hypervolt, typically most folks are putting that under manual therapy. So usually it's not a standalone code, but there's a nice way to document that. I've heard of providers billing under other codes, but I always have to be careful as the manufacturer. There's only certain things we want to recommend. But again, I think if you follow how you're using the tool, right, if we're talking about sensory or neurological input, if we're talking about soft tissue work, et cetera, I think that there's a couple ways, depending on the patient, that it is appropriate to bill. So, all right, so there's a good chunk of you guys who've stuck with us, so I do really appreciate that. If there are any questions at this point, we're here for you. So any questions at all? Let me try to fill the silence. So Nick, what's a big takeaway? So you said earlier in the presentation, you're always surprised how many people maybe aren't using percussion or vibration in their clinic, but what's another takeaway, piece of feedback you consistently get from the NRT course?
Yeah, so that's always the biggest one. I think two things that I would say there is just the freedom to look at the nervous system without like having to know all the time exactly what's going on, right? When you just talk about getting the system in a situation where it can heal, those complicated things, like I can remember early in my career as a clinician, somebody walk in, say right after a car accident, it was like, just like I had to know if it was C4 or C2, like I just had to know. And it's like, get them calmed down, right? Use the systemic approach, calm down the system, then it's going to localize, right? And it'll give you the freedom. So the ability to treat those really acute scenarios where everything's just blown up and just, okay, there's some freedom here, to also the complicated, well, it's not a back, it's not disky radicular pain, it's not just a muscle tear. What am I missing, right? And when you start looking at the sensory nerve and you go, oh, it's that sensory nerve. Okay, well, where can that get entrapped? And it just gives you a whole nother little assessment piece for the things that just don't act like you think they should. It's not a textbook presentation. That's the two sides I've seen the most.
Yeah, and in the evaluations and stuff, I think that's one of the biggest things that we consistently see is it opens up their eyes to a bigger view of what's going on, as you said, right? It's not a course about this or that. It's a course about all of it. And looking at things, again, speaking of dry needling is non-specific. The body, when you do something to the body doesn't know if you're an acupuncturist, a PT, or a DC, right? It acts physiologically. So there's a physiological response. And that's really what we're trying to get through here is being able to take those physiological responses by adding things to the body and then allowing the body to essentially heal itself, right? And providing an environment for that to do that in the most efficient and effective way we can.
So a couple quick questions that came up. I could answer this, but I'm gonna let you guys. Does the NRT course include dry needling?
No, it does not.
So I think one of the really cool things about the NRT course is, which Nick I think may have mentioned earlier, but it's really designed for folks who either can't needle, right? Like if you're a therapist on the West Coast of this country, the United States, right? You cannot dry needle unless you get your acupuncture certification or license, or I think for folks who maybe you don't want to meet them, right? Or I think, again, it's a great way to take that neurological model that you guys are so well known for and learn how to apply it through some of these other complementary synergistic tools. So, right, percussion, vibration, cupping, instrument assisted.
Right.
Another anonymous question came in for contraindications, and I'm not sure if that's for all these therapies or specific, but I'm just going to kick that one to you for contraindications to come to mind, and I'll fill in anything from a Hyperice standpoint after that.
Yeah, I know the Hyperice website does a great job of contraindications and precautions online. In the course, we dive deep into that. There are several that I don't know if it's appropriate to go through all of them here, that we have the time to do that. The Cheatham 2019 has several articles on contraindications and precautions for instrument assisted massage that we reference, and kind of along the same lines for cupping. So, different things along bleeding disorders, pregnancies, cancers, post-surgery. There's certainly things you need to be careful of when you're adding dosage. And again, I think when you think more than just, okay, how do I create tissue damage and trauma with a tool, and you think about what you can do from a systemic, it'll give you options to treat in those precaution scenarios. But there are certainly things you got to be careful of.
Yeah, absolutely. And if anyone has questions on Hyperice contraindications, they're specific to product, right? The Hypervolt is different from some of the vibration tools from Normatec. I'll just say they're all FDA cleared medical devices, all extremely safe, really no adverse events to date on our products. So very happy to provide you the list of indications per product, any contraindications, as well as the research supporting the evidence, the full library. I think we've got 40 or 50 studies specifically done on RTEC, and we have new ones that are actually coming out in the next couple months. The question did come up, is this recorded? So this is being recorded, and we'll share it with everyone who registered ahead of time. So I think at this point we're pretty much at the end, but any final questions, we'd love to hear, and we'll give it one last call for questions. All right. Well, with that, I'm sharing my screen again, just so again, you guys can see the contact information, and it is in the chat here. So if you have any questions for our our expert panelists and educators here, please reach out. Any questions at all related to integrative dry needling, right? info@integrativedryneedling.com. Any questions for Hyperice? I'll even take complaints. I like the good, but I'll take the good, bad, and uglies. I'll take the bad and ugly as well. But truly, anything at all, rehab@hyperice.com. We'd love to make sure you're directly connected with a member of our rehab specialist team. So one last thank you so much, Frank, Nick, just truly a pleasure. Cannot thank you enough for your time here today.
Thank you. Thanks for having us.
Sure, appreciate it.
Cheers. All right. Bye, everybody.